you guys. Good morning. So no disclosure relevant to this talk. So, we've always been taught this algorithm. I think after having doing this for the last 5, 6 years and dealing with this, I think there's no good algorithm. I think your algorithm has to change. It has to be dynamic based on what the patient presents and what the anatomy is. You should be willing to move on to the next. So when you see a SFA CTO, these are the things which go into your head. What is going to be your approach? Are you going to be predominantly endo, or are you going to think this is a patient better served with surgery or a hybrid option? And when you see a SFA CTO, make sure you go through all this anatomy in detail before you start doing anything. What does a proximal cap look like? Does it involve the common femoral? What does the main body look like? What does a distal cap? And also don't forget what the clinical characteristics of the patients are. So the next thing you determine is, what is my primary axis? How will I deal with the CTO? And all this is determined by, predominantly by what the CTO looks like, what the morphology is, what the aortoiliac and common femoral anatomy is, and also your skill level and, what kind of surgical backup you have. But whatever it is, just be careful not to jeopardize the surgical zones, because, you always need a bailout strategy. Very, very important. I personally feel contralateral CFA strategy is the best. Why? Because we've done it a million times and it works great. And obviously, in certain cases, you have to think of alternative axis, and we'll talk over it. So here's a case where we did an antegrade because it's such a tortuous iliac, and this was an elderly patient. Obviously, when you have kissing iliac stents, or when you have patients with EVARs. So here's a case where we had to use a brachial approach because the CTO pretty much starts from the pelvis. Now, I've been moving away from brachial and been switching to axillary axis because axillary artery seldom gets affected with PAD, like probably 2 to 3%. And I think if you know how to manage it, it's a pretty good option. And usually I take care of them with either perclose, and some rare instances you end up using some covered stents. So radial axis, I think the two biggest problems is, not all equipment can fit through the radial axis. The principle behind is amazing because it's analogous to the coronary concept, but the fact that I can't put in all the stents through that or all the devices through that, and also you can't deal with complex lesions. So here's a case we had to access the fem graft to take care of the CTO. And again, make sure you talk to your surgeon and partner with them to do these cases. This is a case where we had to go popliteal because the previous brachial artery ended up with some complications. Again, this has to be done with ultrasound. So the next thing is, how do you approach the proximal cap? You see the C-top calcification, that's what it is. But in real life, you see a whole bunch of variable options. So this is a favorable caps, nice beak, far away from collaterals, far away from the profunda. These are some unfavorable caps. So unfavorable caps are usually calcified. They are flush occluded and neurosomal, often involving the profunda femoris and the common femoral arteries. So the next thing is, once you determine where the proximal cap is, it's important you find the right spot. So as you can see on the video on the right side, the wire is going into a collateral, and there's a chance you can perf this. You won't realize it then, but you will definitely see that happen later on. So readjust your catheter, make sure you find the right spot, pay some time to get into the proximal cap. It's very, very important. Avoid the spiraling you see because you're actually dissecting around it. So try to get inside the lumen if you can. If not, at least definitely avoid the spiral. It's important when you see, sometimes, these patients present as claudicants, but they actually, end up having some acute thrombotic disease. So when you see some angiographic pictures like this, think of thrombotic disease. Very important. The other things you could do is you can try and use a catheter to fish for caps. We can try sometimes EVS, but that probably, it needs a little more expertise, needs a little more of dealing with it. Now, just 1 or 2 slides about the devices, which, the specialty devices, and actually the TruePath has been taken out from the market. I think end of the day, you're going to pick 1 or 2 devices, and you're going to try and stick to the wire and catheter algorithm. And you should be able to get through most of the CTOs. And also, needless to mention, the cost aspect. This is another way to loosen the proximal cap, where you blow up a balloon and dissect. So you actually create an intentional intimal dissection. The other one, which they adopted from the coronary, is you anchor a balloon in the profunda, and you can try and pierce into the actual CTO. Basically, you're trying to get more support. So this is another where you put a buddy wire in and then you try to loosen the calcium with the back end of a stiff angle glide wire to loosen up the cap. Next thing is how do you cross the main body? When you see a catheter sail through so easily, we like to think, oh, we are good, but think of thrombus, please. Very, very important. The loop technique. So the first thing is how you create a loop, and you see how the wire dances, and the dance is equal to the diameter of the SFA. That tells you you're pretty much inside the lumen, and that's when you create the loop and you advance it. And when you see the loop, make sure the loop is less than the diameter of the vessel, so that way you know you're not piercing out or dissecting away. And the feel, as you do more of these, you'll know it's more a push as opposed to a slice. The ISR CTOs are tricky because you have to find a way to make sure you get inside the lumen. And once you do get in and you perform the loop technique, make sure you take orthogonal views to make sure you're inside the stent. Because even with the loop, sometimes you can dissect through the stent and come outside. So here's a case of a calcified CTO. We couldn't get through. Heavy calcification, and sometimes you have to find the right channel. But personally, I think it's, you get lucky, you can get through. Here's another case of a real heavy calcification. We couldn't get through from top, so we came retrograde through the distal SFA, and I met a roadblock. And then what I did was we ended up doing a transcutaneous calcium fracturing. So when you do this, make sure you don't have any of the nerve bundles there because you can injure it. So essentially, you knock down the calcium, create some channels, and then finally, retrograde, you can get through this blockage.
How do you know where the nerve bundles are? You can't see them.
So usually I do an ultrasound, and people who do a lot of venous ablations, you'll know that it looks like a cotton wool. So, I know the other senior operators have been very, very seasoned. They know where it is just from the anatomy. For the younger guys, I think it's a good habit to get into that, because the last thing you want is to have a great CTO success and the patient have, persistent neuropathy. So when you enter into the distal cap, pay extra attention. Take your time, make sure the diameter of the loop is really small, and get in really neat and slick. That really, really helps preserve the collaterals and the branches. Okay. So this is an outback technique. So you basically orient the L and T, and then based on how you're positioned, you feed the wire into the lumen. Sometimes when you're entering into the popliteal, try to preserve this as much as you can. So if needed, I usually switch away from the loop technique. I go into a 014 wire system, or if needed, this is where you have to go retrograde axis. As you can see on the last picture, I tried outback, it didn't work, and you can see the heavy calcification, but with a straightforward field of wire, it just, found its way up top. So the next thing is, if you're not able to penetrate the proximal cap, you're not able to cross the main body, what is your next strategy? You can start using the pedal axes. And usually I just leave a 014 pedal sheet there, or sometimes just a catheter. You can use the peroneal, but I like to preserve the peroneal because it does give out those communicating branches to the DP and the PT. So try to preserve it. Sometimes you have to upgrade to a 035 system. As you can see here, my confianza wire could not penetrate the distal cap. So this is where I ended up using a 015 system. And usually what I did was, as you can see from this picture, I picked the most diseased artery. So even if I screw it up, that way I don't have to convert a claudican into a CLI. Here's a case where, you don't want to access the distal pedal vessels because, there's only one vessel runoff. So you can access the distal SFA, access the most calcified region, because in case you need to stent, you can put a short covered stent there, avoid the collaterals, and then usually a 4 French sheath is good enough. Here's a case where we couldn't penetrate, get into the stent, so we performed a stent puncture transcutaneously. And then once you get inside, use a Cook needle and use your 035 glide wire. And again, once you get your wire in, make sure you take a bunch of orthogonal views to make sure you're inside the stent. Here's another case where we had a calcified SFA CTO. I couldn't get through from either side, so we directly punctured the occluded SFA CTO. And then after feeding a 4 French system, you can see, you confirm on the ultrasound that you are inside the lumen. You can see the catheter, which has the tram track appearance. The next thing is you cross from up top, cross from below. What do? You try to meet the two wires. Now, vascular people have been doing this for a long, long time, but coronaries just gave it a term called tip-in. But the bottom line is you find that part of the artery which is calcified or CTO, which has the least amount of space, and that's where you feed the wire, and that's the trick. If you can't get this through this, the next strategy is, you snare the wire. I recommend you use an EN, which is basically a multi-loop snare. There are some other devices in the market, but get familiar with one or two techniques. What are the other advanced approaches? So here, you basically dissect into the CTO after ballooning, and then you actually snare the wire out. These usually end up with stents. So this is the CAR technique adapted from the coronaries. So here's a case where we couldn't get through from below, from above we failed. So what we did was we ended up ballooning that portion, and then finally we used an outback and re-entered into that zone. Here's another case right at the popliteal zone where we use the catheter to target and then get our wire through into it. This is some advanced techniques which I've seen a lot of the Asian counterparts do it. So they use two wires, one with the IVUS, one without, and based on how it's positioned on the ultrasound and the IVUS, you can then guide your CTO wire into the reconstitution zone. Again, this needs a lot of expertise. Transcollateral, I would say this is like pretty much the last resort. Do it with somebody else because you don't want to tear that, cause a hematoma, and jeopardize the existing collaterals. Then again, this is transcutaneous ultrasound wiring. Again, needs a lot of expertise. And then finally, you can build your own technique. So here's a case, heavily calcified right distal external iliac. We punctured the distal SFA, the heavily calcified common femoral. Again, this was not a surgical patient. We were able to get through that, gut flow into the profunda, performed an IVUS, made sure we're interluminal, went ahead, did a rotational atherectomy, created a channel, and then we were able to come through from below. But remember, safety, safety. So essentially, keep in mind, what is the patient here for? Is it claudican? Is it CLI? Diabetic? What's the renal function? Spend a little time assessing the anatomy. Really spend some time. Very, very important. Personally, I think retrograde CFA is the standard. Don't stall. Keep your algorithm. Keep changing. Change it for every single patient depending on what they present to the table. Remember, when you see calcium, respect it. Learn to work your way around it. Again, be very, very, very careful when you're getting into the distal zones, the popliteal zones. And finally, remember of surgical zones. Thank you.
Beautiful.